Hello everyone, I would like to present our Departmental Quality Improvement Project, Implementation of COVID-19 Macro on CT Chest Exams, Quality Control Metrics to ensure adherence to standard reporting and communication, which took place at ChristianaCare Hospital in Newark, Delaware. We have no disclosures to declare. As you may know, the outbreak of COVID-19 was first reported in Wuhan, China on December 31st, 2019, with the first reported case in Delaware on March 11th, 2020. In order to provide concise reports for optimal patient care within our hospital system, we decided to implement guidelines published by the RSNA in March of 2020 for CT chest findings for suspected COVID-19 cases. Prior to use of this lexicon, our CT reports lacked consistency in conveying CT findings of viral pneumonia, potentially leading to confusion amongst the ordering clinicians. In order to assess compliance, a system-wide macro was created. The radiologists used the macro on CT chest exams in all patients with suspected COVID-19 infection, and when the radiologist wanted to invoke the possibility for COVID-19 pneumonia in patients without clinical suspicion. To ensure compliance, a COVID-19 quality control rotation was created. A radiologist was assigned each day to review the previous day's CT chest reports to ensure appropriate usage of the macro and whether physician communication was performed on relevant exams. All cases that fell into typical or indeterminate categories were required to be communicated to the clinicians. To oversee compliance, a committee of 3 attending radiologists and 1 resident radiologist was created, which met weekly to review discrepant or non-classified cases. Our project's foundation was the RSNA's consensus statement on reporting chest CT findings related to COVID-19, summarized here on this chart. Radiology findings were categorized into 4 categories: typical appearance, indeterminate appearance, atypical appearance, and negative for pneumonia. A total of 313 CT chest exams performed between March 25th to April 29th were analyzed. Of these, 35 were known PCR positive, 37 were negative, and in 241, the COVID status was unknown. The macro was appropriately used in 92% of the cases. A total of 53 cases were typical indeterminate, and of those, 98% were appropriately communicated with the clinicians. To consolidate the usage of the designated COVID macro, we implemented a departmental policy to use a macro on chest CT examinations for patients who, number 1, are clinically suspected to have COVID without a resulted PCR test, 2, are known PCR positive, 3, who had a prior negative PCR but are still suspected to have COVID, and 4, have incidental findings on chest CT even if not clinically suspected to have COVID. The macro was not meant to be used for any examination that did not fully image the chest on CT. Of the 313 studies evaluated, the aforementioned criteria was appropriately applied in 86% of cases and inappropriately applied or not applied in 8% of cases. In this chart, you can see the diagnostic accuracy of our department's original reports. This data is based on the original interpreter's categorization prior to review by the COVID Review Committee. As you can see, there was an expected trend based on severity of categorization, where 70% of patients with typical appearance for COVID on CT chest tested positive for COVID, whereas only 6% with negative for pneumonia categorization tested positive. An unexpected additional positive outcome of utilizing the RSNA criteria, 9 cases of eventual positive COVID pneumonia were brought to the ordering team's attention by radiology, all of which were being assessed for an unrelated illness. Lastly, our COVID Review Committee assessed whether there was a major or minor discrepancy within the use of the correct category within our COVID macro. A major discrepancy was considered when the original assessment was changed from negative for pneumonia or atypical appearance to indeterminate appearance or typical appearance, and vice versa. As you can see, only 3% met the criteria for major discrepancy. In conclusion, instituting a macro for COVID-19 in CT reports and implementing quality control metrics improved the radiologist's compliance to use standard language in their reports, providing clarity for clinicians and aiding patient management. Thank you for your time.